All right, so this one today, right, or this morning rather, is all going to be on shock, right? So we're just going to kind of go through the basics of what is shock, how does it actually present, what different types of shock are there, what are some of those terms that we actually use for all the different types of them, right? We may sprinkle in a little bit of some treatment, but really I just want to kind of get through all of the shocks just at the very kind of basic foundational level. That's going to help you with your ability to identify what type of shock, or first off, identify that your patient is in shock. Second off, what type of shock is it? And then third, you can take that and go to the next level with what your treatment is going to be for it. So for all the different types of shock, right, sometimes it's a good just kind of framework shift. For people, if we said, instead of using that word shock, we use the other more fancy name, right? Also known as hypoperfusion. So sometimes when people shift over and use hypoperfusion and think about the actual word itself and the breakdown of that, sometimes that helps, and it helps with the anatomy and physiology side of it as people start working their way through. Okay, so which way does vital signs go? Is respiratory rate doing this? Heart rate's doing that? Blood pressure's doing this? Right? So shock or hypoperfusion, doesn't matter to me which one you use, just whichever one is going to help you with it a little bit more. Okay? But breaking it down, hypo, right, is low or not enough, right? Low perfusion, right? So perfusion is, really all about getting that good stuff in throughout the body and getting the bad stuff out, right? It's always that two-sided coin, right? So much of our focus as EMTs and paramedics and everything is about making sure that we're getting enough oxygen to the patient. They have enough sugar, they have enough of a blood pressure, they have enough whatever it is, right? So we're all focused at getting that good stuff in to the patient. We don't always think about the waste products and kind of the long-term, removal of that type of stuff. Just because most of us are dealing with the patient for a relatively shorter period of time, right? So we're really focused on maximizing the good, less so on eliminating the bad, right? But that eliminating the bad is just as important, right? You can't have one without the other, right? If we're exclusively focused at getting the oxygen in, but we're not eliminating the carbon dioxide, they're going to become acidic and toxic, right? And similarly, if we just focused on that without getting the good stuff in, they would be hypoxic and, crashing on us, right? So it's just as important as it is to get the oxygen, the sugar, the whatever it is into the patient, is the removal of those waste products, right? That's why things start compounding when we add in like kidney failure or liver failure, right? Those two big organs involved with filtering and detoxifying the blood, right? If we start losing those, even though the brain, heart, and lungs might still be going, now we're going to be starting to build up that toxic internal environment. Right? So some of the definitions that are there for perfusion, or then in turn hypoperfusion, is really about that ability of the body to circulate enough oxygen and nutrients to meet the demands of the cells and tissues throughout the body. Right? So every single cell inside the body, amongst other things, right, needs to be able to utilize the blood sugar that's floating around, blood glucose, and the oxygen that's floating around, right? We need an appropriate temperature. We need other nutrients and stuff in there too, but kind of initially, fundamentally, let's just talk about these two, right? So perfusion is circulating enough blood, enough oxygen and nutrients to meet the cellular demands of all the individual cells throughout the body, and all of those cells are part of larger tissues and organs, right? So being able to actually support all of those. So that's one, right? That's one definition, right? Circulating enough oxygen and nutrients to meet the cell's demands. The better shock definition, or the one that's built out a little bit more, is circulating enough oxygen and sugar and nutrients to meet the demands of the cells and appropriate removal of the waste products. That's now best. That's kind of encompassing that full, balance in the body, that homeostasis, where we're getting enough of the good stuff in and we're appropriately removing those waste products. Right? And so that's kind of really the kind of best rounded definition of perfusion, is addressing the fact that it's getting the oxygen and nutrients in and appropriately removing the waste products. So those waste products, let's talk about them, right? Primarily, we're looking at that oxygen use in the body, right? And that's when we actually go into, cellular metabolism, which is a whole crazy complex system if you actually get that far into it, right? But for starters, right, with metabolism, is when things are going well and our body has enough oxygen and enough sugar, but really enough oxygen, we call it aerobic metabolism. Aerobic means there's plenty of oxygen. And so what happens is, as the cells use oxygen, right, the goal is to make energy. That's the goal of every cell, is to make energy so the cell can keep doing the things that that cell needs to do. Whether it's a cardiac cell or a liver cell or a skin cell or whatever it is, right? The cells need energy to keep doing whatever those cells are specialized to do. Right? And that energy in the body is called ATP, or adenosine triphosphate. I'll write that out for you. Adenosine triphosphate. So ATP is energy in the cells, energy in the body. Okay? So that's the goal. As the cell gets the oxygen, gets the sugar, is the cell wants to keep doing whatever that cell is supposed to do. So if it's a liver cell, it wants to keep detoxifying the blood. Right? But in order for it to do that, it needs to have this constant energy source. And it makes this energy by using oxygen, using sugar to keep generating that energy. So uses oxygen, makes energy, and creates a waste product. Waste product, which is carbon dioxide. Right? So as our body uses oxygen, it makes carbon dioxide just as a waste product, which is phenomenal in terms of waste products, because we're already circulating the blood throughout the entire body. So if it can just pick up carbon dioxide, we have a pulmonary system that's designed very, very, very well to just eliminate gas, right? So in terms of this waste product, all we have to do is keep breathing for our body to keep eliminating this waste product. That's the beautiful thing about it, right? It's easy to get the oxygen in. It's easy to get the waste product, carbon dioxide, out. Right? So that's when everything is going well. Right? When we're in nice, happy, healthy, aerobic metabolism, which again means we've got plenty of oxygen in the system. Right? So that is not shock. Right? That's not hypoperfusion. Right? In hypoperfusion, we're saying we're not, right? We're getting too little perfusion. We're not getting enough oxygen and nutrients to those tissues to meet their cell, the demands of the cell. And we're not removing the waste products as well. Right? So we're going to take our same definition and we're going to say it's inadequately circulating oxygen and nutrients around the body that doesn't meet all the demands of the cells. And in that circulation, we're not eliminating the waste products as well. So what happens is we're getting less oxygen into the body, and we're getting a buildup of some of those waste products. Right? So instead of plenty of oxygen and easy to get rid of the waste products, now we're getting not enough oxygen, and we're retaining too much of those waste products. Side note, Jeopardy question for the day of what structure inside the cell generates ATP? It's the mitochondria. It's a random A&P nugget for you today, right? The mitochondria is actually that structure inside of a cell, and it's that structure that's responsible for generating that ATP. All right, so shock. I'm going to freehand this one today. Just try out a different format compared to the one the other day. So shock, we said now we're not getting enough oxygen throughout the body. And we're not, at least something somewhere is getting hypoperfused. It's not getting enough perfusion. It's not getting enough blood flow and blood pressure. It's not getting enough of the good stuff, the oxygen and nutrients. And it's not eliminating the waste products as well, right? Hypoperfusion. Right? So this starts to get into, okay, if we say we're not getting enough oxygen and sugar, right? Not getting enough oxygen, now we say it's anaerobic metabolism. Right? Aero is referencing air, right? So that aerobic metabolism is in the presence of plenty of air or oxygen, ideally. And then when we add in, where are my pins? Anaerobic, now it's saying without air or oxygen. Right? So we're getting not enough oxygen to meet those cells. Right? Well, the goal is still the same. Right? The goal that the body has is still, let's make energy. Right? Because if that cell doesn't make energy, that cell can't do what it wants to, which means that cell is going to die. Right? So without enough energy, without enough oxygen, that cell is going to die. Right? So the goal is still the same. The goal is make energy. But a huge component of that ability to make energy was that we had enough oxygen in the system. And so now in shock, or now in hypoperfusion, we're not getting enough oxygen, so we're not able to make as much energy. And so that's where the body looks for other sources and says, okay, how can we make energy? Because we're going to try to stay alive, right? It's a backup system. We're always going to do something to try to stay alive before the body just kind of gives up and we go into cardiac arrest completely. So the body starts to figure out, okay, where else can we generate some energy from? And I say, okay, well, we can, break down fats to make some energy, and we can break down muscles to make some energy, right? Actual muscle cells, right? Fat and muscle tissue. Right? If we break down those, we can at least make a little bit of energy, right? A little bit. It's not as much as before, right? When we had plenty of oxygen, right? We were able to make a lot of energy. And it was a very easy waste product of carbon dioxide to eliminate. But now when we don't have enough oxygen, right, so we start burning fats and muscles, we only make a little bit of energy. Right? But in terms of our desire to stay alive, a little bit of energy is better than no energy. Right? So we achieve the same outcome of making energy in shock, in anaerobic metabolism as we progress into that. We're just not making enough. We're certainly not making as much, right? So aerobic metabolism is not designed to be a long-term life-sustaining function, right? It's a more kind of short-term acute thing right now. And that's why if you're working out, if you're doing aerobic exercise, cardio, walking on a treadmill, right, you're getting plenty of oxygen into the body. If you're doing anaerobic metabolism, you're working out really, really hard, right? Your body is not getting enough oxygen, so it starts burning off fats, right? That's why people will push to that anaerobic exercise to help with weight loss and things like that, right? So it's because we know the body will actually shift and break down other structures to generate that energy, right? So we start breaking down fats and acids, and we make a waste product. Right? But the primary waste product that we develop now is a lot of things like lactic acids. Right? And lactic acids are not as easy for the body to actually eliminate as just breathing, right? To get rid of that carbon dioxide. We said when we have plenty of oxygen and we're making carbon dioxide as a waste product, we're breathing just fine. And every time we breathe, we're getting in oxygen, but we're also breathing out the carbon dioxide. So as long as we just keep breathing, we're going to keep eliminating that waste product. Right? Super easy, doesn't take a lot of energy in the body. Right? But once we start saying we don't have enough oxygen reaching these cells, and these cells convert over to anaerobic metabolism, right? The body's going to start breaking down other stuff to generate energy. But the waste product of lactic acids is not just breathing to eliminate it. Right? So those lactic acids stay in the body a little bit longer. It takes a little bit more work to get rid of them. But again, we're still alive. Right? Those cells are still making energy. Again, just not as much. Right? Once we slide over to anaerobic, right, we're only making a little bit of energy compared to the lot of energy that we were making when we had plenty of oxygen. So shock, again, just one more time, so we're going back to it, is hypoperfusion, right? Which means we're not getting enough of the oxygen and nutrients to tissues in the body, and we're not eliminating those waste products as well. Right? So getting less of the good stuff in, and we're building up more of those waste products. All right. All right. So then really getting into shock, if we say, okay, the kind of core issue in shock, right? If we just simplified it down, stripped down all the fancy words and everything, we'd say the core issue is that something somewhere in the body is not getting enough oxygen. It's hypoperfused, right? It's not getting enough of the good stuff. A lot of different reasons why, and we're going to get into those. That's all the different types of shock. Right? Lots of different reasons why something in the body cannot be getting enough oxygen, but the kind of core issue of not enough oxygen is really the same, right? That part's consistent. So there's a lot of consistencies across the shock presentations for all those different types of shock. Right? And we just have to break it down a little bit to figure out what's unique about the different ones. So in your books and stuff, it'll usually give you what they call a perfusion triangle. Perfusion triangle. And the perfusion triangle is the three things that you need to be able to adequately circulate enough oxygen and nutrients throughout the body and eliminate the waste products. Right? So we need three things. Right? We need an appropriately functioning heart that's pumping everything well enough. We need blood vessels that are able to vasoconstrict and vasodilate, right, to keep our blood pressure up, right, to keep our blood pressure sufficient so that we can actually circulate that blood throughout the entire body. And we need an appropriate amount of blood. We need an appropriate amount of the red blood cells that carry that oxygen, and we need an appropriate amount of the fluid, which is where most of that carbon dioxide is dissolved in, so that we can get it back to the lungs to eliminate it out. So the perfusion triangle is the heart, the blood vessels, and the blood. Or in the book, it will say you need adequate pump function, you need adequate container function, right? The container is the blood vessels, right, that are containing the blood as it's going around, right? And the appropriate amount of fluid in the system, right? So I don't like using container, right? I like saying pipes. Right? we need appropriately functioning pump, pipes, and fluid, right? Those three are the key things for the perfusion triangle, right? It's an adequate pump, pipes, and fluid, which is really saying we need an adequately functioning cardiovascular system, right? Cardiovascular system is the heart, the blood vessels, and the blood. All right. And hand in hand with the cardiovascular system, right? It's not kind of immediately a part of the perfusion triangle, but the heart and blood vessels and blood is useless if we don't have a respiratory system that's able to actually get in the oxygen, right? So anytime we start talking about the cardiovascular system, we have to remember it's so intertwined with the respiratory system, right? You can't have one without the other or the whole system fails, right? So we're going to put the oxygen to the side for a second. We're just going to talk the pump, pipes, and fluid for the perfusion triangle. So all shocks are a breakdown of at least one of these three components of the perfusion triangle, the pump, the pipes, or the fluid. So we're going to work our way through. So if it's a pump problem, so we're saying the heart is not doing its job well enough. Right? So there's some categories, right? At its core, right, when we say heart, one of the types is cardiogenic shock. Cardio in the word, telling us it's the heart, right? Cardiogenic shock. Now, if we're saying the heart itself as a muscle is not able to pump strong enough, it's not able to pump well enough, then we can start to think about, okay, well, what could cause that? Right? And probably the most common cause that will be given is somebody that had an MI, a heart attack, right? And now we have that infarction, we have that dead spot of tissue on the heart, and now that heart muscle isn't able to actually contract sufficiently to pump out enough of a blood pressure to actually circulate blood throughout the entire body. Right? So it could be somebody has a myocardial infarction, that process actively happening, and they're going into shock because that heart is kind of giving up and failing. Probably going to be your most common one that you'll get in scenarios. If it's not somebody acutely having a heart attack, maybe they had one in the past, and so now their heart doesn't work as well because they had an MI in the past. And we might call that congestive heart failure. Congestive heart failure, again, most commonly, they had an MI in the past. So again, something has to structurally be wrong with the heart if for the heart to not work well, pumping blood forward. Right, so MI and CHF are going to be your MI probably by a mile is going to be the most common scenario, followed by CHF, which is like the chronic result of somebody that typically had an MI in the past. And then the third, really not kind of commonly talked about, is maybe they have some sort of valve disorder, valve problems, where the issue is the heart is able to pump, but when it contracts, some of that blood actually goes backwards through the heart as opposed to forward. So if we just kind of isolated out the left ventricle in our heart, left ventricle contracts, that blood should go out to the aorta, right? But maybe because of a mitral valve problem, right, that valve between the left atrium and the left ventricle, maybe when that left ventricle contracts, instead of all of that blood going out to the aorta, maybe some of it goes backwards up into the left atrium, which again is going to result in less blood being pumped out into the body, which means there's less oxygen getting delivered throughout the body, which will fit the criteria definition that we had for shock, right? That something somewhere is not getting enough oxygen and nutrients. And in this case, it's because some of that blood starts working backwards. I don't want you to linger too much on that one. It's just really, it's true. It is a potential source of cardiogenic shock. Just seems like the vast majority, and by the vast majority, I mean literally like every question that I can ever think about for cardiogenic shock is centered around an MI or a CHF patient. But valve problems, it would apply as well. Now there's another category that technically falls into this pump problem section, and that would be the obstructive shock category. There's a lot of different types of shock, and then we also have different categories of shock as well. So the obstructive shock category is saying something's blocking the heart from working properly. The heart itself is fine, just something's blocking it from working properly, from being able to appropriately circulate blood and oxygen throughout the body. And so again, there's the same, there's a couple ones that really fall into this as well. Right? A couple injury problems. Right? So one of them is a tension pneumothorax, where we pop that lung and that air pressure is building up inside the thoracic cavity. And as that air pressure builds up, eventually it starts pushing and pushing and pushing and pushing and pushing stuff. Right? And so it starts pushing a lot of pressure onto the heart. And so the heart and the aorta and the vena cava all get squeezed and compressed by all this air pressure that's building up inside the chest. And so when we start squeezing on the vena cava, we're restricting the amount of blood that's coming into the heart, and that air pressure is constricting on the heart, means that heart's not going to be able to pump out much blood in the forward direction. And so if we're reducing the amount of blood coming into the heart, we're going to be reducing the amount of blood getting pumped out the other side, which again will result in something somewhere not getting enough oxygen and nutrients and removal of the waste products. Right? But the key is this tension pneumothorax, all that is that air pressure. The heart itself is fine, it's just being compressed by the air pressure. So if we remove that air pressure, and the heart's going to be able to expand out, fill up with a lot of blood, pump a lot of blood, everything will be fine. So we do a tension pneumothorax trauma session later, really diving into that a little bit more. Right? Another possible cause is cardiac tamponade, which is again, very similar thing. We have that pericardial sac around the heart, and that's getting full of fluid or full of blood, and it starts compressing the heart. And so just like with the tension pneumothorax, because of that compression on the heart, it's not able to fill up with a lot of blood, which means it's not going to be able to pump out very much blood out the other side. Right? So it still is a restriction of blood flow getting into the heart, which is going to restrict the amount of blood flow that the heart's able to pump out the other side. Same thing again, if we remove that fluid pressure, which we can't, but if we remove that fluid pressure from that pericardial sac, that heart is now able to expand out. It's going to start contracting again well, circulating a whole bunch of fluid. Okay. So kind of like cardiogenic shock, there's two main ones, and then a third that's not used as often. Obstructive shock, it also has the same. There's two main ones for scenarios of what type of shock is it type of thing. For the obstructive shocks, it's tension pneumothorax and cardiac tamponade. And the third one, which isn't as often mentioned, but it does fit the criteria as well, is a pulmonary embolism. Right? If you have a big enough blood clot in the lungs, right, the heart may be able to pump mechanically fine, but if it can't actually circulate that blood to the lungs, we're not going to be able to get any oxygen into the bloodstream. Right? So it'll fit that criteria of eventually, right, we're not going to have enough oxygen reaching the body because we're not able to actually get that blood flow to the lungs because we have this clot actually building up in the system, or this clot inside the lungs blocking that blood flow. So it fits the criteria of those obstructive shocks, not as commonly used for it. I'm not saying don't remember them. I'm not saying you can't get a question with those, just not as often are we going to see that be the category. So cardiogenic shock and obstructive shock, those are all pipe problems or pump problems. Geez, those are all pump problems. If you take like PHTLS, pre-hospital trauma life support, right, they use slightly different terminology. This cardiogenic shock and obstructive shock is probably what it's what our main textbooks and everything utilize for the terminology. PHTLS will say that the MI-CHF, where there's an issue with the heart itself, they'll say is an intrinsic cardiogenic shock, that the issue is actually inside the heart. The issue is the heart. And these obstructive shocks, they will say is an extrinsic cardiogenic shock, right? Where the issue is still the heart, but the real issue is something outside the heart that's blocking it from working properly. I always like that, blocking it from working properly, a blockage is an obstruction. That's where the obstructive shock term came from. Right? Something is blocking it from working. Right? Other books, they'll call it an extrinsic cardiogenic shock. The issue is the heart, but the issue is something outside the heart is making it not work properly. Right? So most common, they'll just call it cardiogenic shock, and they'll call it obstructive shock. Just understand, sometimes they might phrase it a little bit different, and we got to kind of break down and slow down with the terms and say, okay, cardiogenic, I understand that's the heart. Extrinsic is outside or external, right? Extrinsic, outside the heart. So something that's outside the heart making it not work properly. Tension pneumothorax, cardiac tamponade, and maybe a pulmonary embolism. All right, pump problems. So the next one is our pipe problems. Right? And again, it's the same initial problem of not enough oxygen reaching something inside the body. So generally because we're not getting enough blood flow or enough of a blood pressure throughout the entire body. So these pipe problems are all vasodilation problems, right? Those blood vessels are too big, right? If blood vessels are too big, the pressure going through them is lower. Right? So as the size of that container gets bigger, the pressure gets smaller. Right? So as the volume of the container gets larger, the pressure inside gets lower. Right? So on these, we're saying the blood pressure is getting too low, which means we're not able to actually circulate enough of that blood flow sufficiently throughout the entire body because that pressure is getting too low. So pipe problems are vasodilation problems. They'll get the umbrella term where the category is called distributive shock. Right? So all of these examples that we're going to go through are distributive shocks. Right? There's a problem with distributing that blood flow throughout the body is because their blood vessels are too big. Right? So the analogy I've always liked to use that kind of highlights this, vasodilation versus vasoconstriction thing is if you hooked your kitchen sink up to like one of those tiny little coffee drinking straws, like where all the water was going to go through that tiny little straw, and you turned your sink on full blast, that's going to be a high pressure fluid shooting through the end of that straw, right? If all the fluid through your kitchen sink was going to go through that tiny little straw, it would be very high pressure because that pipe is so small. Now, if we took that coffee drinking straw off and we hooked a fire hose up to our kitchen sink and we turn it, same kitchen sink, it's going to put out the same amount of fluid, right? But it's going to go through a much larger pipe. And so when we open that kitchen faucet on full blast, the pressure of water coming out the end of that fire hose is going to be much, much, much lower, right? It's going to be a lot weaker of a flow, is because it's a bigger pipe, right? Or same thing, go outside, get a hose, right? Turn the hose on and see how the fluid is coming, how the water is coming out of the hose, and then put your thumb over most of the opening. So there's a smaller opening, it becomes high pressure, right? So it's just showing us when it's a smaller opening, a smaller pipe, it's going to be higher pressure. When it's a larger opening or a larger pipe, it's going to be a lower pressure. So these are all caused by vasodilation. So some of the types would be anaphylactic shock, so that severe allergic reaction. And when we get that allergic reaction, right, or we get exposed to whatever it is that we're allergic to, one of the things that our body releases a lot of is a chemical called histamine. And histamine causes, amongst other things, causes vasodilation, right? So it's this histamine release throughout the body, which is resulting in those blood vessels just opening up and vasodilating. That's why we have drugs like Benadryl is an antihistamine. And when we give somebody epinephrine or an EpiPen, right, it blocks histamine release. Right? So a whole lot of the issue in anaphylaxis is that release of histamine. Another type is septic shock. Right? In sepsis or septic shock, we have whatever sort of infection that's going throughout the body, and with the infection are all those toxins that are associated with it. And what those toxins do, man, is they start damaging, right? You can almost think about it as like poking little holes in the walls of the blood vessels. And it just kind of damages those blood vessels, and those blood vessels just get weaker and weaker and weaker, and they start opening up, right? Opening up the blood vessels, right? So those toxins, right, start damaging the blood vessels, which start to cause our vasodilation. That's why in the hospital, right, they're going to give antibiotics or whatever it is for that particular type of infection to start combating and dealing with these toxins. And they're going to be doing medications to cause that vasopressive effect, right, that vasoconstrictive effect, and giving a lot of fluid to try to fill up those big blown out vasodilated blood vessels, right? But at its core, we got to deal with the source of the problem. Right? And the source of the problem is whatever sort of infection they have that's progressed bad enough to the point that we have full-blown, sepsis, that we're actually getting this vasodilation throughout the body. So another one of the distributive shocks, like I said, I know I only got the hour session today, so I just want to make sure that we get all of the categories. We could do an entire day just talking about each of the individual categories, and we will. And we'll work our way through all these, just because, again, all the shocks, recognition that your patient's in shock, identification of what type of shock, and then that guides the treatment for that type of shock, is just foundationally critically important to be a good provider, but also a critical skill to be able to actually get into or pass exams in class, pass national registry and everything, is this whole shock category. All right, so another type of distributive shock is neurogenic shock. Right? And neurogenic shock is typically trauma. It doesn't have to be, you could have a medical cause of it, but it's typically, severe central nervous system trauma, spinal cord trauma, significant enough brain trauma. But most often we're probably going to be talking for the scenarios and questions that you would probably see is probably a spinal cord trauma, mechanism of action, or a scenario is probably going to be a spinal cord trauma patient. And what happens is if we get that spinal cord trauma and we cut off that nervous system signal, well, think about it. I mean, if you're paralyzed, your muscles aren't real tight, right? Everything is relaxed, right? So if we don't have that nervous system input, muscles just relax, right? And what happens is we have wrapped around our blood vessels, our smooth muscles, that those muscles contract and relax to cause vasoconstriction and vasodilation. So if we cut off that nervous system signal input, those smooth muscles around our blood vessels are just going to relax. And relaxed, smooth muscles around our blood vessels is vasodilation, right? So once we lose that nervous system tone, right, that muscle tone, everything relaxes, it causes our vasodilation. All right. And then the third that we have, or fourth rather, is psychogenic shock. Just that, it's psychology, right? So that's somebody that, sees something that, maybe they're, very afraid of, or they have this reaction in the body, and the kind of mind over body power connection that's there, right? That psychology results in a temporary widespread vasodilation. Person probably passes out. Passes out means it kind of shuts the brain off for a second, right? Takes the psychology out of the equation, lets the body kind of recalibrate itself, right? Body takes back over, vasoconstricts everything back down, and you go back about your business, right? You start to feel better, recover, right? I know it's for me, right? It's one of the things I always share it because it's an embarrassment to myself, but whatever, right? I don't do well with needles, right? It's terrible. I can start IVs on people, no problem. I have zero issue when the needle is going that direction. Okay? I have a different framework if it was a tattoo needle coming the other direction. But if I got to get a shot or if I got to get blood drawn, I'm no joke. I'm that guy that has to look away because I'm probably going to pass out. Right? It's ridiculous. Right? I'm going to pass out. So a little bit is kind of that psychogenic reaction, right? Is, my mind starts thinking about it, whatever, right? And it causes this vasodilation, right? So I get all woozy or whatever, I got to lay down, otherwise I'm going to go down, right? So it's that kind of temporary widespread vasodilation because of some sort of psychological stimulus or event, somebody that, sees blood and they faint, right? Or that needle coming at me if I get to get a shot or blood drawn or something like that. And that causes that vasodilation, right? And body kind of takes back over. So a big one for that in order to identify is some sort of kind of psychological stressor, right? Or psychological event, right? Somebody that has a phobia to something gets, exposed to that, right? But the big one is it's a temporary widespread vasodilation. Temporary widespread vasodilation. And so this is where we can go, okay, we can go a step further on another day and kind of work our way through all these categories. And we can say, okay, neurogenic shock, right? That's my trauma one. Sepsis, right? Septic shock, where I'm dealing with that infection. I'm probably going to need a fever in that scenario, right? Psychogenic, neurogenic, anaphylactic shouldn't have a fever, right? So fever could be that variable that helps me identify this one as opposed to any of the other ones. Anaphylaxis is that allergic reaction. So maybe they tell me my patient is itchy, has hives, has airway swelling. Well, that only shows up in anaphylaxis. It doesn't show up in the other ones, right? So beyond just understanding the similarity that these are all vasodilation problems, is take a look and say, well, what one or two things would I need in a scenario that would clue me in for anaphylaxis that wouldn't clue me in for any of the others? And what one or two things would I need for sepsis that would clue me into that one as opposed to any of the others? It's the best way to kind of look at these. Look at what's similar, just as a broad concept called shock. And then once we get comfortable with that, look at what's unique between them. And again, that's going to be how we actually go about identifying our patients in shock, but then going that step further and saying, not only do I know my patient's in shock, but I know they're in septic shock because of, you know, these 1, 2, 3 reasons that I have. All right, so pump, pipe, and fluid is the last one. All right. Fluid problems. And fluid problems is pretty easy. We have hypovolemic shock, which is low volume, right? Just not enough fluid in the system, right? Somebody that's severely dehydrated. Right? Maybe they've been vomiting and diarrhea a lot and not eating and drinking well, right? So just not enough fluid in the system, not enough volume, be hypovolemic shock. Right? The other one we could say is hemorrhagic shock. Hemorrhagic shock is just a step further saying this is not just we're dehydrated, we specifically don't have enough blood, like red blood cells. So this is, you know, some sort of bleed that's actually been happening, right? Trauma or medical, right? Trauma is the obvious one. It's going to be the one that we probably think about most often when we talk hemorrhagic shock is they got traumatically injured and they have this arterial bleed where they're splurting out blood or they're bleeding into their abdomen, right, after a car accident or something. So generally trauma, right? But you can have medical, right? You could have somebody with a bad enough GI bleed that they've been bleeding for long enough that, you know, they're going into shock because of that blood loss, right? So most of the time trauma is what you would probably expect for that. Hypovolemic, again, you know, a little bit more, you know, not that they're bleeding out, more on the dehydration side. So maybe they've been sick, not septic, because that's a pipe problem, but maybe they've just been sick where they have been, you know, vomiting and diarrhea for too long and not getting enough fluid and everything into the system. So that was the pump, pipes, and fluid, right? We had our cardiogenic shock, we had our obstructive shock, and a couple different causes for obstructive shock. On the pipe problems, we had anaphylactic, septic, neurogenic, and psychogenic, and those were all called distributive shocks as a category. And then we had hypovolemic shock and hemorrhagic shock. And it's really 8 different types of shock in a few different categories. And the nice part is there's not really other ones that we talk about. It's really those. So it's a relatively small list that we can kind of start working our way through. And like I said, we'll do session after session after session. We'll start to work through all of these different types of shock and treatments and everything just because, again, it's so important. We want to hit on one last point in these last few minutes, which is circling all the way back to the beginning and kind of establishing what our body is going to do in response. So we said we're not getting enough oxygen somewhere, to some place inside the body. Something somewhere is not getting enough oxygen, right? So this cell that's over here that's not getting enough oxygen, it's going to send up a little flare signal up to the brain saying, hey, dude, I don't have enough oxygen. We got to get more oxygen in the system. And the brain's like, cool, I know exactly how to deal with this. This is super easy. We don't have enough oxygen. Let's just start breathing faster. Right? It's that increased respiratory rate. Right? So increased respiratory rate is, one of the first changes that we see as a patient progresses into shock, right, is based initially just off the brain's got to tell the brainstem breathe faster. The brainstem sends that signal down to the diaphragm to start breathing faster. right? Because the core problem is not enough oxygen, so the brain responds by doing what it can immediately to get more oxygen in the system, right? So that increased respiratory rate is one of the first things to happen. Sometimes they will say what they call early altered mental status changes, which might be just a little anxiety, restlessness, right? That patient that just can't, quite get comfortable. They're moving, they're anxious, they're still alert and talking to you, right? They're not like altered, unresponsive. Sometimes they'll say that's actually the first thing, right? Is that body knows something's wrong, right? That body is kind of getting that feeling that, it's not, doing so great, that something somewhere is not getting enough blood flow, right? So maybe we get that anxiety, restlessness first, but in terms of vital signs shifting, that respiratory rate goes first. And then the brain says, well, if we're breathing in all of this oxygen, we need to kind of pump faster to deliver all of that oxygen throughout the body. And so that heart rate should go up next. The heart rate should go up next. This is in terms of vital sign shifts, not everything physiologically happening in the body, just the vital sign shifts. Right? Is let's get more oxygen in the system, and then let's pump that oxygen faster to deliver it. What's also going on during this process, right, is activation of that fight or flight sympathetic nervous system response, right, which starts vasoconstricting and shunting that blood to the core. Shunting blood to the core, right? So our body starts to prioritize making sure we're getting enough blood flow and oxygen to the super important stuff, right? So we get all of that vasoconstricting, that shunting of the blood to the core away from the less important stuff. And that's all in an effort to try to, maintain a blood pressure, right? Because we have to have a sufficient amount of pressure to actually be able to distribute this oxygen that we're getting into the system, because we started breathing faster and we started pumping faster, right? But depending on the cause of the shock, what will happen over time if we don't start correcting the problem, right, is eventually, right, that blood pressure starts dropping. And so initially, we say they're in compensated shock, right? Just by the fact that we're compensating, we're still able to maintain a sufficient enough blood pressure, just not hypotensive. Okay? But as we start losing that battle, as this fight or flight response doesn't kind of keep up, because they're still having this anaphylactic process, or they still have this spinal cord trauma, or they're still having this MI, whatever the cause is, if that doesn't get fixed, eventually that's going to start to fail, and we'll go to decompensated shock. And amongst other things that happens in decompensated shock, it's really where that blood pressure starts falling off. As we start losing the battle, as that blood pressure starts going. And then if it really doesn't happen, then eventually the next step is that last step, and we will say it's irreversible shock. And irreversible shock is really everything is giving up, right? His blood pressure has already been dropping, it's continuing to drop, but now that heart rate starts to give up, the respiratory rate starts to, then literally the body is starting to shut down. Is that irreversible shock progression? Now everything's given up. We're not even trying to get more oxygen in. We're not even trying to pump faster, right? It's because everything is starting to die, right? Because of that poor perfusion, right? Everything is starting to fail, so things are just starting to shut down inside the body. So this increased respiratory rate, increased heart rate, and dropping blood pressure is kind of the classic 3 vital signs, right? If you see those, your mind should think shock. Okay? If you see those, your mind should think shock. Okay? There's one exception, which is in neurogenic shock, where we get that spinal cord trauma. It's the one type of shock where the heart might not actually get the signal that it needs to pump faster, right? Because of that central nervous system trauma, right? Is the heart might not get the signal that says we need to go pump faster to try to circulate this oxygen. Right? So if you're reading a scenario, you're like, okay, altered mental status, hypotension, we've got this trauma emergency that happened, right? If you're reading a scenario and your mind is thinking shock, and then you see a low heart rate, that should be like a big giant red flag number that does not make sense. Because we would expect that the heart should start pumping faster to try to help with this compensation, right? To try to help keep the body going okay. Right? So if you see a low heart rate, should really slow down, reread things carefully, and figure out what's going on. And the one type of shock that they'll probably lob you up a softball with a slow heart rate is neurogenic shock. Right? So that's kind of one of those unique things that will go a step further for helping you identify the type of shock. And again, really kind of for simplicity's sake, you can just think about it as because of that, brain or spinal cord trauma, is the heart's not getting the signal from the nervous system telling it that it needs to actually pump faster. All right. Oh, power-packed little hour right there. All right, anybody have any questions on this? Like I said, I mean, just trying to get through all the different types of shock is really, kind of the takeaway from today. It's just the categories and what's going on with them. Like I said, we'll start going further into all the individual shocks and our treatments for them as well.